So you all heard that recording is in progress. Very pleased to have our presenter today. I am going to introduce her and turn it over to her. If you have questions, please post your questions in the Q&A. It's on the other side if you look at the bottom bar of your screen, on the other side of polls, there's Q&A. Go ahead and plop that in there. I will try to answer your question. Dr. Oliva will try to leave a few minutes at the end of her presentation to respond to any questions that you might have. But this is a lot of information. And again, you'll have the slides in a PDF on the website in a couple of days. So on that note, Dr. Oliva, I want to take a moment to introduce her, and then I'm going to turn it over to her for the presentation. She received her PhD in developmental psychopathology and clinical science from the University of Minnesota. She is currently a senior evaluator for OMHSP's Program Evaluation and Resource Center. She is also an investigator at the VA Center for Innovation to Implementation, CI2I, which is kind of fun, at the Palo Alto healthcare system. She is also, and the reason why we invited her to speak today, VHA's National Opioid Overdose Education and Naloxone Distribution Coordinator, which is a mouthful. And she also conducts research on opioid overdose education implementation. She also works with interdisciplinary teams to provide resources, technical assistance, training, and education, and that's why she's here today. She also helped develop and implement our stratification tool for opioid risk mitigation, STORM, and I think that'll be a little piece of the presentation today. So on that note, I'm going to hand it over to Dr. Oliva. Elizabeth, take it away.
Yeah. Thanks so much, Gail, for inviting me. So today I'm going to cover a lot of information. So if we want to cover the Veteran Health Administration's multifaceted response, clearly it's going to be a lot of information, but I'm hoping to distill down and really highlight your critical role as psychologists in really helping out with the opioid epidemic within a pandemic. So as a disclaimer, I know that there may be some non-VA folks. Most links to resources are internal VA links, but when possible, I have included external links. And honestly, if you contact me, my contact information is at the end. Happy to try to figure out how to get you whatever you might need if there's something on here that you like. So just to set the stage, because the multifaceted approach to this epidemic was the topic, we did write in 2017 a viewpoint talking about how the VA is addressing the opioid epidemic. And at that point, we had talked about 4 broad strategies to address the opioid epidemic, including education, pain management, risk mitigation, and addiction treatment. So you can see on the left-hand side, that this is all of these things I kind of pulled out are things that psychologists can actually play a role in. So I'll talk a bit more about OEND. In terms of pain management, if you're not already involved in it, there's a lot of efforts to do step pain care, and interdisciplinary teams are critical to that, and that's where a psychologist is amazing. And Joint VA DoD Pain Education Program, if you're not aware, has a really great set of educational materials to really help folks to get up to speed in this area. And there's also been a big push towards complementary and integrative health approaches as well. From risk mitigation perspective, we have had the Opioid Safety Initiative for going on a decade within VA, and as well as a number of different tools to help providers identify patients who may be at risk for adverse events who are prescribed opioids, and that's where the risk mitigation comes in. And also one thing you can also help with is medication take back. So we know a lot of opioids that get used tend to be those of friends or family members. So really encouraging patients to take those back is important and something that you could add to your wheelhouse. And in terms of addiction treatment, buprenorphine in the VA, we now call this in general medications for opioid use disorder. And we have a huge effort within VA to do that. So I'll talk a little bit about that. as well as the Psychotropic Drug Safety Initiative and treatment for substance use disorders. So you can see this on the right-hand side. There are so many ways in which psychologists really can help out with the response. So I like to start with kind of and finish with this bottom line up front. So we are in the midst of a huge and alarming increase in drug overdoses, and overdose prevention is really needed now more than ever. So your efforts are really needed now more than ever, and I'll show you the data that really support that. So I'm really excited that you were able to join this and kind of learn more about what we're doing, because we really need everyone's hands on deck to really address this. So using that same framework that I had started with, education, pain management, risk mitigation, and addiction treatment, it's been 4 years since that paper. So what I'm going to do is really pull out things and highlight things that I think are important right now for you to be thinking about in this response. So this is just an overview of what I'll be covering in each of those domains. So just in terms of setting the stage, we were already in the midst of an epidemic when this pandemic happened. And there was a lot of concern at the very start. And I'll show you how those concerns were really validated with some of the data that we're seeing now. So we have found that there has been a tremendous increase. We knew that there would be an increase, but we didn't realize it would be so much. So just between February 2020 and February 2021, the most recent data we have from the CDC, there have been over 22,000 more deaths in the past year. That is a 30% increase. And it is, like I said, astonishing. I think, again, we all knew that there would be an impact, but we didn't realize how big of an impact it would be. This is in large part due to synthetic opioids that are flooding the illicit market, that are tainting a number, not just opioids being adulterated with illicitly manufactured fentanyl, but also cocaine and psychostimulants and methamphetamine. So this is partly one of the reasons why there's been this huge increase. I pulled this NPR piece because I really think it helps underscore what our role, and I don't know, I know this is public service psychologists. I'm not sure which areas of public service you're in, but at least within the VA, I'd like to drive home that on the left-hand side, when officials say the increase was driven by the lethal prevalence of fentanyl, as well as pandemic-related stressors and problems in accessing care, at least within VA, we should not have that happening to our veterans. And so really underscoring that we can play an important role during this time of these pandemic-related stressors and this increase in fentanyl to really ensure that we're keeping veterans safe and making sure we're doing all that we can to help keep them alive during this epidemic within a pandemic. One of my favorite papers, something that you may want to look back on later on, is this paper by Mark Ilgen and Amy Bonnert that talks about understanding the links among opioid use, overdose, and suicide. They talk about kind of two competing hypotheses that obviously are complementary and they're not mutually exclusive. The deaths of despair, opioid use as a way of coping with lack of opportunity, and the supply side hypothesis that greater availability and a rapid decline in drug pricing has contributed to these increases. I want to note that these increases were seen prior to the pandemic, prior to all these numbers. So if you look at this, I was just showing you we're close to 100,000 deaths, right? If you look on the left-hand side, we're up to almost 100,000 deaths. In 2000, it was 41,000. We've over doubled that in the last couple decades. And so in general, it's really important to think about how we can address these. And as psychologists, you are well positioned and well trained to really address a lot of these underlying issues that impact these overdoses and deaths. So just some of the things I'll talk about in my in the rest of this talk, but I just like to highlight one of the table that shows the goals and interventions for addressing the risks of overdose and suicide. And I'll show you some data why we actually look at both suicide and overdose. First of all, a lot of the factors are overlapping in terms of predicting outcomes. And I'll show you some really compelling data, particularly among patients with opioid use disorder, how they have among the highest rates of suicide among veterans. So in terms of these goals and interventions, identifying who's at risk. So there's a lot of different ways, and I'll talk about how we do it in VA to identify patients who may be at risk, as well as the prevention. So right now, talking to psychologists, treatment for mental health conditions, number one, right? CBT, again, something that's well within your wheelhouse. Patient-centered taper of opioid dosage. I'm going to talk a lot more about this later because I think psychologists have an important role in addressing the patient-centered tapering. And I would love to have folks step up and really take ownership of this because I think it's one of the gaps we currently have in this area. And I think, again, a lot of your skill set is really important in addressing the issues that I'll discuss later that happen around the tapering process and discontinuation of opioids. Again, OEND we'll talk about, as well as medications for opioid use disorder. So I'll be hitting a lot of this. And again, you can see that this is also something that Bonner and Ilgen highlight as important interventions. Another thing I just want to mention is that if you are working in a healthcare system, most of the people who die of overdose have had some touch point in the system, an opportunity to intervene to actually prevent death. So this is one of my favorite studies out of Massachusetts, looking at people who died of fatal opioid overdose. And they found that in the past 12 months, at least 1 in 2 of them had some touch point. They had an opioid prescription, opioid detox, they had a non-fatal overdose. Some of them were released from incarceration. Some of them had injection related infections. So again, these folks are touching our system. And honestly, if we could just cut this in half, it would be amazing, right? So there are these touch points and really critical to make sure we leverage them to reach out and prevent overdose death. So this is the data I was promising. So the National Veteran Suicide Prevention Annual Report last year had this nice breakout showing who the rates of suicide among individuals with different mental health and substance use disorder conditions. And what you'll see is that that blue line, the dark blue line, tracks with bipolar disorder. People with opioid use disorder are among the highest rates of those with suicide, more so than depression. One of my favorite poll questions to do before I present this data is typically, which of these conditions, has the highest rates of suicide? Everyone wants to say depression, but opioid use disorder, by and large, is way higher than those with depression. So just really important data to underscore the importance of this work and reaching out to patients with opioid use disorder. So starting with the first section, education, I'm going to focus on OEND, and there are internal and external links for folks. So what is it? Whenever I talk about it, I always underscore that this is just one of many things that VA does to minimize risk of opioid-related adverse events. We have lots of other things that I'll be talking about, but this is not going to be a panacea for everything. It is one way in which we keep people alive so that we can keep engaging them in treatment and offering them other sorts of interventions. So the target patient populations, we initially started with patients with OUD and patients prescribed opioids, but data are suggesting also targeting patients who recently discontinued opioids. I know, novel, it's kind of a weird thing, but I'll show you the data and some of the rationale behind that, as well as patients with substance use disorder generally, especially stimulant use disorder, given that Health Advisory Network data I showed you earlier showing how most of the rises in deaths have been related to illicitly manufactured fentanyl, particularly among those who are taking stimulants, cocaine and methamphetamine and amphetamine. So whenever I talk about it, I also like to break up the OE and ND parts because there's so much focus on the naloxone distribution, but there is a huge gap in patients' understanding of how to prevent an overdose. We can give out millions of kits, but if people don't know how to recognize or respond to an overdose, like family members or friends who are bystanders, then those naloxone prescription and kits could go unutilized and there would be a life lost when there could have been a life saved. Moreover, I would love if every single patient we've given it to never needed to use it because they actually learned what to do to prevent an overdose. And again, having done this work and worked in residential treatment to help with educating, it's amazing how people who've been in and out of treatment programs for decades still don't understand that, for instance, just mixing opioids with alcohol could actually put them at risk of an accidental overdose. So there's a tremendous amount, and right, education is bread and butter of psychologists. So this is a key thing that I think you could really be helpful with in terms of teaching patients how to prevent an overdose and what puts them at risk. So how does naloxone work, just in case folks aren't aware? Basically, what it does is opioids are binding to the receptors responsible for breathing, and naloxone kicks those off to allow folks to start breathing again. It's highly effective. Really, if there's no opioids on board, there's no ill effect of giving it. It's super safe, which is why they've allowed it to be given to bystanders, because it acts quickly, and it's really easy to use. 90% of people are able to use the naloxone nasal spray, for instance, with zero training. And so because it can take minutes to hours to die of an overdose, that's why ensuring bystanders and laypersons have it is critical, particularly among rural veterans who may have a longer time for when emergency services might be able to come by. The big thing, though, is that the effects of naloxone start to wear off. And so it is possible, depending on what types of opioids they're using, for the opioid overdose to come back. So that's why part of the education is really ensuring that they're calling for emergency services and making sure they're watching the patient to just make sure that more naloxone may not be needed. So in terms of the VA's OEND program, the national program launched in 2014. We see it as an opportunity to discuss risks of opioids. Really, we've always thought of this as something that could be helpful to providers, saying, these opioids that I'm prescribing you are so risky that we may need to talk about an antidote, right? And that really, I think, helps underscore how risky these medications, for instance, prescription medications may be. And we always talk about it as a few minutes of training that could save a life. And so we have made it within VA at no cost to at-risk patients. There was CARA legislation that eliminated copays for naloxone in training, and that has actually been codified in federal rules and regulations. It actually takes effect, the official rule, next month. So that means that forevermore, there will never be a veteran who has to pay for this. So please help us get OEND to at-risk veterans. We also have a VHA Rapid Naloxone Initiative that encompasses both OEND as well as ensuring VA police are equipped with naloxone and equipping select AED cabinets on VA campuses with naloxone. We want to make sure that no veteran dies on our watch. And so this is partly why we are also equipping the VA police and AEDs with naloxone. And so we have a ton of toolkits in case you haven't, in case your site might be interested in implementing. And we also won the 2020 John M. Eisenberg Award in National Level Innovation in Patient Safety and Quality for this work. In case there are any QI people out there, there's a really awesome roadmap for implementation and quality improvement. In my clinical psychology training, I got zero education in implementation science, and actually how do you translate these evidence-based practices and make sure people actually use them and implement them. So the VA's OEND program has actually been used as an exemplar of a theory-based approach to mapping barriers to implementation strategies. I was thinking about this slide because I remember one of my prelim questions was, do we have theories or frameworks? So that's debatable, but the point being that there's actually a lot of work out there that can help with identifying barriers and how you can actually, for whatever it is that you're working on, and how you can actually overcome them and improve uptake. So you can look at this if you're interested in doing any quality improvement work. It's a really helpful roadmap that helps walk people through. And in addition to OEND, the rapid naloxone was also discussed and mapped on to their roadmap as an exemplar as well. So as I mentioned, we did get the John M. Eisenberg Award, which is a big deal within VA. It's awarded by the Joint Commission and National Quality Forum. And one of the things that's in the booklet that we talk about is just really how much impact our system can have when everyone works together toward a common goal of preventing overdose among veterans, and really emphasizing that we're all in this together. And we really need to figure out how to ensure rapid availability of naloxone to prevent overdose deaths. Moreover, this is important, we also need to couple that with life-transforming medications for OUD treatment. Naloxone's an intervention, medications for OUD is a treatment, and we really need to make sure we're doing both. So in terms of critical junctures for OEND, as psychologists, one of the big things, is provider education. So just making sure you're all trained in OEND and that naloxone is available to staff as appropriate. There's a lot of staff, for instance, that work out in the community. Naloxone, having naloxone available in case of overdoses they come upon out in the community among the patients they're serving is really important. Moreover, the OE part of OEND is in the scope of many providers. So again, that patient education piece on how to prevent, recognize, and respond to an overdose. And again, just a few minutes of training that could save a life. It's really remarkable, this intervention. In terms of identifying patients, you can use fancy tools, but honestly, any patient with an OUD, any patient prescribed opioids, any patient with a substance use disorder is probably, easy enough. And you probably know patients on your panels or that you're working with that fit the bill. Within VA, again, we do have a lot of dashboards that I'll talk about a bit later. And then in terms of the education piece, right, we recommend providing it at intake or screening because we know that there's often some time between intake and actually getting patients in. So really ensuring that you're offering naloxone at that point and then also at treatment start to re-review and see if they may need another prescription. And in residential treatment, just making it standard, part of broad training to the residential milieu, not just at-risk patients, but this is a community issue, right? And this is a public health emergency. So we need to really make sure that there's broad training and that everyone knows how to recognize and respond to an overdose. And so this also will, I think, help with making sure that when they leave the residential program or just in general, that they are equipped with that knowledge. Tons of VA OED technical assistance. I'm not going to go through it all, but there's just a lot available if you're within VA. And if you're not within VA, there's quite a bit even still that we've made available externally. A lot of our materials are available on our external sites. This is one of the main risk reports that we use to help identify patients and see how we're doing nationally. You'll see we're at the top right hand, the number of naloxone patients. We have 314,000. This report was run a couple days ago. And there you can see there's different ways in which we classify risk groups, and you can see the national scores in terms of how we're doing. Clearly a lot more room to go and a lot more room to grow, but this is much better than anyone in the public sector. We also have a national call, and this is just some examples of what we cover in these calls. So we cover OEND and special populations and Veterans Justice Outreach, HUD-VASH, so in some of the homeless programs. And you can see what I love on the bottom left at the Cincinnati VA. They ensure that all veterans in their substance use program get OEND, and they again screen all admissions for risk of overdose and get it to them at that admission date or when they're screening. And so this has been super helpful in making sure that they get naloxone to all patients who need it. It's great. We've also within VA have updated academic detailing OEND resources. So if you're not familiar with academic detailing, they're amazing. And so they are clinical pharmacists, and they make a lot of helpful tools and resources to support implementation of evidence-based practices. So here are the new naloxone materials. We have a provider guide, and I'll kind of go through. This is what the provider or clinician guide covers. And there's really nice infographics, talks about dashboard, really walks you through. I think one of the pieces I like most is it does give you, you can see on the right-hand side, how to have the conversation about naloxone, how to ask about it and things like that. They've also done some really good work because remember I showed you data about the increases in or the high risk rates of patients in this group having suicide and their risk of suicide. So they have a lot of really helpful information about suicide prevention in this context. So lethal means safety, right? Locking up opioids and such, and really having how to have that conversation about lethal means, right? So there's, again, these nice conversation starter types of infographics as well. This is the patient guide. For those of you who have seen our previous work, it used to be a single trifold brochure front and back. We're now at 4 pages just to make the font a bit bigger for patients and to really cover things. It's a tiny brochure that's actually available in the depot. So this is the patient guide that gets handed out. So again, covering opioid overdose prevention. So this is the whole first and second pages, safer use of opioids, things that put you at risk for an overdose, and then recognition on the left-hand side, and then response following. So 4 pages that really cover all the key things that need to be discussed. They also have these nice bigger, so these are like single pages. Each of these boxes is a single page. This is how to actually administer the naloxone nasal spray, where they pull in also the prevention, recognition, and response information. But it's a lot nicer when you're actually going over the medication itself and how to administer it. So it's a bigger font, and it's like kind of like a nice booklet. So it's a lot more information. So this, I think, can also be helpful. One of the things I like most about this one, so again, this just really walks you through, is the bottom right-hand side. There's this never use alone hotline, because one of the biggest things we try to, let people know is that using alone is one of the biggest risk factors for death, for dying of overdose, because no one's there to respond. So there's actually a hotline and a website you can go to that will be online with you while you're using. And if you don't respond after a certain amount of time, they'll call emergency services and give them your location. So really helpful harm reduction information in this booklet. There's also a nice, am I at risk for an accidental overdose? This is actually meant to be like a behavioral activation tool. And so you can, just have this in your waiting rooms and things like that. So just to really help with activating them and thinking about their potential risk for an overdose. We also have quite a bit of work going on this year to increase naloxone for veterans with OUD specifically. So by the end of the year, we're hoping for a national 25% increase in patients with OUD who have naloxone. Lots of support around this. We're actually developing clinical reminders in our electronic health record to help support this. And so what this will look like is, it will trigger if a patient doesn't have, has an OUD, but no naloxone in the past 335 days. We use that weird number because what we found out was that there are a lot of patients who just ended up, not being on anyone's radar, because usually most things have a 1-year look back. And so we're actually doing 335 days to give providers 30 days in advance of the year that's used in these metrics to reach out to patients who may be needing a new prescription. So there's also, this is what the expanded, sorry, it's a little fuzzy, but the point being, it's very simple, straightforward. It covers just education. The VA, you can click on the VA pamphlet, one of the ones, for instance, we just looked at, and then there's video resources. So if you want to just show the video to a patient, and at the bottom, there's an order. And if you can't order it yourself, for instance, you're a psychologist, right? You can actually, there's a click box on the bottom, provider notified of requests for naloxone prescription. So theoretically, you could just go through all of this and then notify that provider for the patient needing naloxone. To further enhance and leverage the electronic health record, we also have clinical reminder order checks. So these will be subsets of that, patients with OUD with no naloxone. So this will trigger if a patient with an OUD who's getting a medication for OUD who doesn't have naloxone in the past 335 days is getting prescribed that. So it'll pop up and let folks know to consider naloxone. And then similarly, for any patient getting a CN-101 or an opioid medication, it will do the same thing. So again, lots of different ways we're really trying to leverage the system to increase awareness and get patients naloxone. So I am now going to shift gears. So pain management. We have a lot of things we're doing in pain management that psychologists are well positioned to help out with. So in VHA pain management, the website is a great external website. Honestly, it's great internally or externally. So for VA providers, this is also wonderful. There is a step care model for pain management. You'll see at the bottom left-hand side. You can see it pretty much in every single aspect. There are roles for psychologists. You can see at the bottom, nutrition, weight management, exercise, so nutrition, weight management. You can see mindfulness, meditation, relaxation techniques. In the PACT in primary care, there's also assessment and management of common pain conditions, CBT for pain. There's lots of different things you can be doing to help out. And on the right-hand side, I like to also discuss what's available for patients. So if you're working with patients or veterans, there's a lot of really helpful information on that's on that website for how to manage their pain and different types of exercises they can engage in that might be helpful. So the big thing for psychologists, though, is CBT for chronic pain. We have an amazing program led by a psychologist in the VA, Jen Murphy, and she has, again, it's part of the VA's evidence-based psychotherapy initiative, and they've trained already a lot of clinicians, over 1,000, and they have a network of behavioral pain experts. So if you're in VA and interested in this, please reach out. She's amazing, and this program's spectacular. Because I always love resources for patients as well, what's really nice is that there's a website with the path to managing chronic pain, as well as, sleeping better, who doesn't want to sleep better, coping better without drugs. So a really great treatment works for vets.org website. So if you haven't seen it, check it out. And then again, like I said, this is like your smorgasbord. So if there's anything I talk about that piques your interest, I'm hoping you might follow up. But the next thing I'm going to talk about is STORM, the stratification tool for opioid risk mitigation. So what is STORM? It identifies patients at risk of overdose for overdose or suicide-related adverse events. It's a predictive analytics model that underpins this whole system. And what's really nice about it is it doesn't just identify patients, because I think there's lots of different ways you can identify patients. But what it does, it provides patient-centered, evidence-based, clinical practice guideline recommended opioid risk mitigation strategies. And I really feel like that's what differentiates it from a lot of the other approaches out there. I think that as psychologists, you'll be fascinated to see this, that mental health and substance use disorders and non-opioid related factors have higher odds ratios than opioid related factors in predicting overdose or suicide related events for patients prescribed opioids. For instance, I'm not sure how familiar any of you may be in the morphine equivalent daily dose opioid world, but there's often been they wanted it to be no greater than 90. Now we're at 50. There's been a lot of differing numbers thrown out, but 120 is pretty high. So, and that's where everyone gets very concerned. However, the efforts spent on that are really significant. And so what I like to use in this, and this is why it's in this box, is 120 MEDD would increase modeled risk for overdose or suicide related outcomes as much as a PTSD or AUD diagnosis. And so what I like to say to folks who are in the MEDD or opioid world is, like, as much time and energy you spend on that, you should be spending on ensuring their PTSD and AUD and other psychiatric comorbidities are addressed. And so this is what STORM looks like. It's very busy, but I'm just going to walk you through it. So left-hand side, this is a patient information, and it gives the risk score. Reassort is another risk classification system. So if folks are aware of that, we also embed that in there as well. And so again, what puts the patient at risk? So that's the next set of columns, the relevant diagnoses. So if you have a patient who's very high risk, they will list all of these mental health, medical, and adverse events. So if they had a previous overdose, a previous suicide attempt, as well as relevant medications they may be taking that contribute to risk, benzodiazepines, other sedating pain medications. And then again, where the rubber meets the road is right here, how to better manage my patient's risk. Here are the risk mitigation strategies. So these are, again, guideline recommended risk mitigation, and they're check boxes with dates to show when these were last employed, and other helpful information, and not just risk mitigation, but also non-pharmacological pain treatments. What other things can we be doing to try to address the patient's pain? Because again, everyone on here is on here because they're prescribed an opioid for pain. And then one of the things that was most interesting to us is that care team and follow-up, we found that a lot of patients, it wasn't that they weren't getting enough care, right? It was like oftentimes it was uncoordinated care. So we do highlight on the right-hand side recent appointments, upcoming appointments, and the color coding will show where they're getting those at to really help with care coordination efforts. So we did have there was a mandate, and it's being updated now, to do data-based case reviews of opioid exposed patients with risk factors. We actually changed the name. The name previously wasn't opioid exposed. It was, with opioid risk factors. But as you can see from the data that I showed you, it's not necessarily that the opioids are what's causing the risk. It's often that there's something, inherent with the patient and their clinical condition and presentation that makes them at higher risk. So one of the things we have done is that for patients identified as being in the very high risk category on STORM, we've been mandating that they receive a case review by an interdisciplinary opioid risk team. And that patients being considered for new opioid prescriptions also need to have a case review by the provider before prescribing. So these are two things. And what's really interesting is this was part of a randomized program evaluation. So we did some really cool step wedge designs to see if we could identify whether or not this actually makes a difference. And what we found is that the outcomes associated among outcomes associated with getting an interdisciplinary case review among patients in the top 1 to 5% of STORM, we found a 23% reduction, or sorry, it should be 22% reduction in all-cause mortality in the subsequent 4 months. So if you're identified and in this and you get this database case review, you can see here, there's also a benefit from actually having that case review done. And so again, I think this is some data. It's really exciting to be part of a team that is, not only, mandating this, but also evaluating it and seeing how it actually impacts mortality. And again, we were stunned, right? I mean, to have mortality shifting this much, these are on the order of like medication interventions, right? And so this was, again, just a case review of patients. So it's pretty exciting. So the thing I wanted to also mention and get on your radar is if you work with any patients prescribed opioids, and again, if you're in VA, pain is one of the most common conditions among veterans, and even outside, just in general, pain's a pretty common condition generally. But tapering and discontinuation are critical periods to keep patients on your radar. So one of the papers we published last year was looking at the associations between stopping prescriptions and the length of opioid treatment with overdose and suicide outcomes. And what we found was that for patients who stopped opioid treatment, so you can see this, the reference values basically were, not in terms of reference values, but just in terms of the hazard ratios, you'll see the number of days is the number of days they were on opioids. So on the right-hand side, so we had patients who were, were on it more acute, so less than 30 days, 31 to 90 days, 91 to 400 days, and then more than 400 days. And so you can see that those hazard ratios increased. For the longer you're on, there was a greater risk for overdose or suicide when you're off. And I think, this is always so hard to interpret. So I love these graphs, which I think really help underscore what the kind of take-home points. So on the left-hand side, these are life tables showing what the length of opioid treatment you'll see on the right-hand side, and the observed overdose and suicide mortality rates. And what you'll see, again, remember, I think everyone's intuition is like, oh, well, if the opioids are risky, then stopping them is less, you'll increase patient safety. But what we're finding is that that's not necessarily the case. What you'll see, particularly among those who've been on opioids the longest, is a very high mortality rate in the first 25 days. So 104 per 100,000 patients, which is gigantic. So you'll see this in the data. And basically in our discussion, we really highlight, in what's highlighted here, that you should closely monitor patients for at least 3 months after stopping opioid treatment, especially those on long-term opioid therapy or those with other risk factors, for instance, mental health and STED comorbidities, and that you need to continually manage and treat pain and comorbid conditions, and importantly, preserve relationships with healthcare providers, especially post-opioid cessation. And we actually had an accompanying a BMJ opinion piece, which really talked about how this OSI initiative, how it can really teach us how to use information to improve patient outcomes. So again, one of the key take-home messages we emphasize in that opinion piece is that we do need to move beyond solely focusing on opioids to address the opioid crisis. Because again, the factors associated with increased risk when patients are prescribed opioids are also associated with risk when opioids are no longer part of the patient's treatment plan. There's actually a little animation or picture I usually pull in these presentations showing, opioids are honestly, if you have a patient with mental health, SUD, pain, all sorts of things going on, and you have opioids are such a small piece of that puzzle. So just taking that away is not going to address all those underlying issues that are present in a patient. And again, kind of just really emphasizing that providers should take a patient-centered approach and stay engaged and communicate with their patients and address those risk factors that place them at risk, regardless of whether or not they are on or off of opioids. Our study was followed up I'm following it up with this amazing Agnoli study that was published in JAMA, I think it was last month, also showing that post-tapering patient periods, so underscored in red, were associated with 9.3 overdose events compared to 5.5 events in non-tapered periods. They're really identifying that these tapering periods actually had higher incidence of these events, both overdose as well as mental health crises. So when with regards to mental health crises, the rate was 7.6 in those being tapered versus 3.3 among those who were not being tapered. So you don't have to look at this. You can look at it later if you'd like to peruse. But one of my favorite outcomes of that paper was a great editorial by La Rochelle Lagasetti and Amy Bonner talking about, do we need to reconsider opioid tapering practices? I think in general, there has been a reconsideration. Some of the work we've done has informed FDA and HHS in terms of a guideline they put out. But one of the things that I think is important to underscore for you is that patients at highest baseline risk for physical and psychological comorbidities, so top left, during and after an opioid taper, who likely weren't an even slower taper, are honestly the very patient population for which a prescriber may instinctively accelerate tapering, right? So a patient's risky, so we want to, take away their opioids because we want to reduce risk, which again is not necessarily the most important thing. So one of the favorite quotes I have from that editorial is that, in almost all cases, rapid or abrupt discontinuation should be avoided. So again, if any of you are working with patients who are on opioids, who are going through a taper, who are going through this, please help advocate on their behalf, because there's been a lot of, I think, and I don't blame providers, right? Providers were told that this was a safe medication, right? That there's no issues. And so you're taking a whole group of folks who for a long time thought that they were doing what was best for their patients and addressing their pain, are now being told, oh, actually those are really risky. And they were never taught on how to taper. So one of the things that's really important is, we need to give people grace, but we also need to be aware and armed with this information to really help advocate and support patients who may be going through a tapering process. Because again, the rates post discontinuation you can see in our data are stark and startling and very scary. So we really need to make sure we're doing the best to really support them. So if you do have providers who may not have had any sort of education on how to taper, because again, many of them have never been never been trained in this, there's a great academic detailing opioid taper tool, and you can see on the bottom left. And I think this risk honestly is highest for those who have been on it for a long time. And so the slowest taper over years, so we're talking years, should be considered for patients taking high doses of long-acting opioids. So just something to really think about and just be aware of. There's also great patient education guides on how to slowly stop opioid medications and what they can be aware of and things to look out for that that they can then share with their provider. So this is available externally and also available in Spanish. And benzos, I'm not going to get into it. Clearly, there's a lot to get into already, but benzos, I am sure you are well aware, are some of the most difficult things to get off of. So there's some nice education on how to slowly stop benzos and how to look for signs of benzodiazepine withdrawal. So next, I'm just going to cover what VA is doing in the risk mitigation in terms of improving post-overdose care. So in the VA, we have really great national note templates to standardize suicide behavior and overdose reporting, and as well as anytime a patient's naloxone is used. So we have a separate report that that can be used when a patient's naloxone is used on someone other than the patient. The reason we have this is because it's really important clinical information, right? That you have a patient who's at risk of overdose and who's around other people who are overdosing. That can maybe identify that, if the patient's still hanging out with those folks, maybe reviewing the relapse prevention plans, seeing if they may need elevated or increased level of care. So the key point though within VA is that we do see these non-fatal overdose events even if it's the person or their bystander, as clinically significant, and opportunities to intervene to improve patient care to prevent future overdose. Again, one of the things we really focus on in this post-overdose care piece is the fact that 1 in 6 people who die of overdose had a non-fatal overdose in the past year. VA has a memo that actually mandates that all overdose events be reported through these standardized note templates. And there's also the one thing I really want to highlight here is the bottom one, that facilities must have a process in place to ensure that these events are reviewed. So if you're in VA and you're interested in this area, please think about how you might participate in the overdose review teams that are going to be reviewing these overdose reports. So there's a lot of SBOR resources to help support your efforts. And I just want to really mention that, again, this is not just documentation. It is meant to provide clinical decision support at the point of care to guide patient care post-overdose. Overdose, although I've been talking about how impactful it is, it's a relatively low base rate event, and a lot of providers may not be keyed into what they should be looking for in addressing post-overdose. So what this SBOR does is really help with post-overdose care. So some of the main changes that will be coming your way if you've already used this is we've embedded, so all of these hyperlinks, if you have substance use, for instance, as a risk factor, we're embedding the screening and treatment pocket cards, the CPG clinical practice guidelines, marijuana use, patient discussion tool, AUD, quick reference guides, brief interventions. We're throwing everything in because we know that providers don't have time to look for all these different things. So we're hoping that by having it embedded, it will make it very easy to address a lot of these risk factors with the standardized materials we've developed in VA. And for unmet pain needs, again, we have pain informational guides, those slowly stopping benzos, things I've mentioned, as well as risk discussion guides. So lots of really cool information. I think the main point to walk away with is that we are really trying to shore this up. And because we know that there are other social determinants, homelessness, for instance, I did not know that there was a 24/7 contact information number for homeless veterans, a call center, or that they're, a phone number as well. So we're hoping that by embedding all this information for justice involvement, legal help, family and social stressors, intimate partner violence, that we will be supporting providers and giving patients the best care during these events. There's also some really awesome work going on in harm reduction generally. So there's a syringe service program directive that's being developed. You can see there's an interim memo, right-hand side kind of pulls out that, it's VHA policy to, first to develop SSPs. It's recommendation that we develop SSPs and ensure that they have access to it, and as well as really addressing stigma in number 6, because we do know it's a common barrier for persons who inject drugs. So really cool work happening on the SSP front. We're hoping to standardize basic syringe kits within VA. Also working on a national note. Danville was the first of 2 places that is actively doing this, and they've given out 2,800 syringes since 2018. They're updating their process and spreading it VISN-wide to again spread this this really important practice. And if you're in VA, there's an affinity group if you're interested in any of this. Really great group doing really awesome work. Fentanyl test kits are also something a lot of people have been asking about. So Tessa Rife, you can see if you're in VA, there's a link to this presentation. But essentially, she's implemented this in San Francisco VA. And there's a lot of information again on this and how to actually get this implemented in your sites. And last but not least, I'm going to end with addiction treatment. In VA, we have step care for substance use disorders. And so this is a step care model. Again, you are important at every single step of this graph. There's clinical practice guidelines that really talk about this, and highlighted on the left-hand side, right? Addressing co-occurring mental health conditions, and then shared decision-making and motivational principles. So again, right up your alley. Medications for OUD, just in case you're not aware of the data, does reduce mortality for those with OUD. Really, really important intervention in our clinical toolkit. And there's a great OUD provider guide if you want to learn more or share with your colleagues. It also includes HIV PrEP. And there's a great patient information trifold, similar to what I showed you before, right? Do you know the truth about opioid use disorder? Again, behavioral activation tool to really help get them interested in learning more about treatment. And then a fact sheet about medications for OUD, what they are, what the different types are, and what side effects to report, for instance. And there's some key messages, right, that academic detailing has, right? Helping identify patients with OUD, getting them OEND, if you're a qualifying practitioner, getting X-waivered, and offering medication as first-line treatment to veterans with OUD. If you're in VA, I love that we have so many resources, but oftentimes people don't know about them or never go and look at them. I liked pulling out these pictures so you can see, or screenshots, because there's a lot of cool stuff they have on their website. So this is the Scout resources. So Scout is Step Care for Opioid Use Train the Trainer. So that's really helping get medications for OUD implemented in our system. So lots of great resources there. This is amazing, guys. I did not know this was on there until I started, trying to pull this together and present. But this is like, amazing resource directory. It tells you all the SUD-VISN points of contact, intranet sites, all sorts of really helpful information. And there's also, as you probably are well aware if you're in VA, so many national calls. But here's a nice summary of all the calls and then the points of contacts for them. And we also have a nice external site on with provider resources about substance use disorder treatment. So you can check that out if you're outside of VA. And just motivational interviewing, probably preaching to the choir, but it's clearly an important aspect of any type of addiction treatment approach. And if you're in VA, there's a great SUD consultation and support listserv or group that can answer questions. So just if you're not aware, please reach out to them. They're amazing. They give really great and timely feedback. And so bonus slide for VA psychologists. I'm wrapping up, guys. We had a whole call on International Overdose Awareness Day, highlighting from all different perspectives what people can do to address the alarming increase in drug overdose. So you can see here, SBOR, we have whole health, primary care, all sorts of different things. In honor of International Overdose Awareness Day, we ask that people commit to at least one new action from these call to action slides. And so similarly, I'm hoping that I can call upon you to think about one of these many array of things I just covered that you might be able to commit to try to address, again, this alarming increase in drug overdose deaths. And again, you are critical to addressing this epidemic within a pandemic. Thank you for your service, for your public service. And to those who are in VA, thank you for your service to veterans. And if you have questions, there is my email. And I did leave 4 minutes for questions.
You did. I am so impressed with you, especially with the number of slides. Thank you so much. I know folks are going to have to drop off. Before I get into, just so you know, Elizabeth, there's one question that I'm going to pose to you, but as people drop off, reminder, if you are a Division 18 member, you get 1 free CEU. I posted the information in the chat. You also will get an automated email reminding you about the survey. Please get the survey done in a couple of weeks so that we can send you your CEU certificate. If you are not a Division 18 member, it's only $15 if you want the CEU, but we certainly encourage you to join because we have amazing monthly webinars just like this one that you get as part of your membership. So on that note, Elizabeth,
I saw the question. So
Kathleen, oh, you did? Okay,
yeah,
great.
Yeah.
Can you do that in a couple minutes or less? That would be awesome.
Yeah, I mean, that's a really great question. I know there's been some questions about, being paternalistic and really wanting to engage patients in this conversation. Like I said, there's been a lot of people like, why don't you just send it to everyone? I'm like, because, it's a provider-patient relationship. Can you imagine us undermining that relationship, that the provider themselves didn't have that conversation with their patients about risks and why they're prescribing this? So I think there's a lot, I can see both sides. And honestly, I have, Kathleen, if you want to reach out, I have some really great examples of people who've done both, who've just melded out. One person said, well, one person thought it was their allergy med. I mean, there's just so many ways it can go wrong. However, in that same example, there was one person whose life was saved, right? So I think with all of these, it's important. And I think you can talk about that at your local level. I can always raise it at the national level, but I think in general, we really don't want to undermine patient-provider relationships, which you can imagine if we meld it to everyone, could really have the risk of doing that.
Okay, Elizabeth, that's going to have to be the last word. Just a reminder, the recording of this webinar, along with the slides of this amazing presentation Elizabeth, we have amazing webinars every month, but the amount of resources that you included in your slides is just utterly fantastic. And so we will do our best to get them posted on the VA section webinar site as soon as we can. Oh, and I see Thoraya is our Division 18 membership chair, so she knows that we would love for you, if you're not already a member, please join us, even if it's just to come to our webinars and get your free CEU. Thank you so much, Dr. Oliva, for all the work you do day in, day out. Your initiative has obviously saved many, many, many lives, and we really owe a debt of gratitude to you for your dedication and commitment, and also for your call to us to actively participate in that. So thanks, everybody. Have a great rest of your afternoon. We'll see you next month. Take care.